Good afternoon, everyone, and thank you for joining RP Presents 2020, Focus on Healthcare. We are going to get started at 3 o'clock promptly, 3 o'clock PST. We're just waiting for the attendee count to increase ever slightly. Good afternoon. Thank you for joining RP Presents Election 2020, Focus on Healthcare. We are going to get started in just about a minute. You all are joining in a muted status. This is a webinar format. Now, the way you can interact with our panelists is using the Q&A option at the bottom portion of your screen. The Q&A box is how you can submit questions during the meeting, and at the panelist's discretion, they can be answered throughout the meeting. Thanks again, thank you for joining. And now I will hand it off to Anthony Gabriel. Dr. Gabriel.
Eddie, I want to thank you very much for turning that over and for the introduction. And welcome everyone. This is our third episode of RP Presents. We've been doing these special webinars quarterly and intend to keep doing them quarterly. Each one of them is on an issue impacting radiology or healthcare more broadly. And this quarter, we couldn't think of a better topic than the upcoming election. And so today, we've got three very distinguished panelists that are going to be talking to us about election 2020 and what the potential impact of that can be on healthcare and also on radiology generally. This election, although of course all elections have healthcare as a significant focus and have an impact on healthcare, but I don't think I can remember one that had as big an impact, potential impact on healthcare as this one coming up in November. So to start off with, I'm Anthony Gabriel. I'm the Chief Operating Officer for Radiology Partners. I'm a physician and I am joined by three very distinguished panelists. Our first panelist is Mr. Ted Burns. Ted is the Senior Director of Political Affairs for the American College of Radiology and is responsible for advancing healthcare policies on behalf of the radiology community. Under his tenure, RADPAC, the Radiology Political Action Committee, has exceeded $1 million a year in each of the last 10 years. Next, Dr. Scott Gottlieb, who served as the 23rd Commissioner of the Food and Drug Administration and currently serves as a resident fellow at the American Enterprise Institute. He is a partner at New Enterprise Associates and a member of the board of directors for Illumina and Pfizer, and is also a contributor for CNBC. And finally, Dr. Geraldine McGinty is a practicing radiologist at the Weill Cornell Medicine Medical Center and also is Chief Strategy Officer and Chief Contracting Officer for the Weill Cornell Physician Organization. She is an internationally recognized expert in imaging economics, has previously served as the ACR RUC advisor, and was also a RUC panel member. She is the immediate past board chair of the American College of Radiology and is the current president of the ACR. Thank you all for joining. Very much appreciate it.
Thank you for having us.
So this afternoon or evening, we've really broken this up into three big topics, five big topics. Access to care, payment reform, COVID-19, trust, and cost and transparency. We'll have questions in each one of these areas for our panelists. And we hope to keep this conversation very conversational and also allow people to be able to enter questions into the Q&A, and we'll try to entertain those if we have time. But before we get into the topics at hand, Ted, I've got a question that I'd like to ask you. And that first one is, can you tell us a little bit about the differences between Republicans and Democrats when it comes to healthcare?
Well, yeah, it's an interesting question. It's one that I think Republicans continue to struggle with. They've been struggling with it for quite some time. If you look at currently with Trump, it's really driven more by HHS and CMS than anything else. Obviously, because he doesn't have the party of his, controlling the House. His party is in a minority in the House. They always want to repeal the ACA. I mean, that's pretty standard across the board with the Republicans. On the Democrat side, obviously, if things were to flip in this election, if Biden were to get the White House, you would obviously look at them to not only keep the Affordable Care Act, but to strengthen it, add a public option. You're looking at, in my opinion, also something that's a little bit on the radar, scope of practice, I think you need to think about as well. And then obviously Medicare eligibility age and a bunch of other factors. But if you were to go on the Republican side, and we're a bipartisan PAC, as Dr. McGinty knows, having been a chair of our PAC board for quite some time, we have friends on both sides of the aisle, and we have supporters on both sides of the aisle. But the Republicans don't have a ton of stuff that they list. And even if you look at the Doc Caucus, which is primarily House Republican members, they really struggled to, back in 2016, 17, really get hold of a solid policy. Whereas on the Democrat side, obviously, they really want to push for the public option. So those are kind of the two perspectives. I do think if also Biden were to win, you would see a lot more legislative and collaborative approach as opposed to kind of a top down. He would really let, as a senator himself, at one point in time, I think he would really let regular order happen, working through the committees a lot more traditionally than currently is being done now.
Thank you. I'm going to put a slide up on the screen right now, and it's from some data that came from a survey done by the Kaiser Family Foundation. And basically here, in most healthcare issues, in this poll, people favored Biden. They thought that Biden had a better plan for healthcare for most healthcare issues. What do you think this implies for Trump? Is this worrisome for him? And this is to any of the three of you, really.
I'll jump in really quickly. If I'm Trump, I probably don't worry about it as much, only in the sense that healthcare at one point was one of the top 1 or 2 or 3 issues going back even to the 2016 election. Healthcare has dipped pretty significantly among issues of most importance to voters now. Now, if you take out coronavirus especially, healthcare is really far down, maybe the 5th or 6th issue. So if you're Trump, it's all about economy. I think what you will see on the Democrat side is really connect coronavirus and healthcare issues and really bring up the healthcare issues, because they know on the Democrat side that is their strength and that's their advantage over Trump and the Republicans.
Scott or Geraldine, is there anything you'd like to add?
Well,
Hey, look, I think that the Democrats are going to try to make healthcare a more prominent issue in this election, and you see that happening with the Supreme Court justice. A lot of the questioning around Amy Barrett is around her potential role in the SCOTUS decision on the Affordable Care Act, because they know they poll well on it, and they know voters trust them more on the issue. Whether or not they can turn the election into a referendum on healthcare, I think it's probably unlikely, at least in this political cycle. But healthcare is going to be a prominent issue in 2021 in the next Congress, because you're heading into a year when there's going to be a lot of accrued morbidity owing to people's lack of healthcare this year. The fact that people have foregone a lot of routine screening, vaccination rates down, so we're going to see a lot of accrued morbidity that's going to be recognized more widely, I think, in some of the analyses that are starting to get done and that will get done. And you're going to probably have some protracted hardship in the broader economy, so you're going to have more people uninsured. And you could well have the Supreme Court overturn the ACA, and so Congress has to come back and re-legislate the Affordable Care Act. So I think those three dynamics are going to make healthcare a pretty prominent issue in the next Congress, even if it's not necessarily a prominent issue in this election coming up in 3 weeks, because it's going to turn on some more acute issues, namely the pandemic.
Mhm. Geraldine, would
Anthony, yeah, I might just add, and Ted said it so well, we do not at the ACR come out for one or other candidate. We have a diverse membership, and we'll have members voting for both sides of the ticket. And a lot of what we have to do is build relationships and play a pretty long game, because as you know, sometimes legislators don't necessarily know a lot about what we do. So we have to spend time building those relationships, building that credibility, so that when our specific issues come to the table, we'll have people who really understand the value of what we do. And we certainly can't afford to have any of those be predicated on what color their bar is here.
Okay. Yes. So with that, there's a good lead in to getting into some of the issues. And the first one that we had on the list there was access to care. And so I'm going to bring up another slide right now. Pull that up. And so this one really here is about coverage. And the slide on the screen shows the uninsured rate. And after we had very significant gains in reducing the percentage of people that were uninsured, we've seen that number start to creep up ever since 2016. And additionally, with COVID, approximately 10 million people have lost their health insurance. People are starting to put off essential care due to concerns about affordability, or just plain and simple that they don't have coverage anymore. How do you see this being addressed? And in particular, how do you think it will impact radiology in 2021 and beyond? And Geraldine, if I could throw this to you at first, and then maybe ask Ted or Scott to join in.
Sure. Well, Scott alluded to the fact that we're already worried that people haven't gotten their recommended screenings. We spent several months not doing essentially non-emergent work. So we're worried about that. And then to think that there are people who won't even be able to get those screenings because now they've lost their job or lost their health insurance. I mean, as physicians, our first duty is to our patients, and we're committed to making sure that high value imaging care is available to them. So yeah, it's definitely a worry.
Building upon this just a little bit, I'm going to bring up, Scott, you mentioned a little earlier about the focus right now with the Supreme Court hearings that are going on. And obviously there's a big case coming up, the California v. Texas case. And here's a little bit of a flow chart that we've seen on this. Right now there's 18 Republican states leading to challenge the individual mandate. And this has raised questions about whether or not the entire law will survive. And right now the ACA is still in effect, but if the law is ultimately struck down, how might this change healthcare? How might this change coverage for the people who have it? Would these people lose their coverage? Do we really know? How should we be thinking about this? How should we plan for this?
I think it is going to be somewhat dependent upon the outcome of the presidential election and the composition of the Senate. I think if Biden wins the presidency, he's likely to win the Senate as well. Democrats will control the Senate, and they'll re-legislate the Affordable Care Act. It reopens it up. And so, they get another shot at fixing some of the policy mistakes and also expanding the policy in certain ways that they've wanted to. So it's going to reopen up a lot of the issues that were debated and lobbied over. If the Supreme Court overturns this and the President Trump wins re-election and the Republicans hold the Senate, they're going to have to come in and legislate something. You're not going to be able to knock people off of coverage that they currently have. But I think the composition of what they ultimately legislate is going to look a lot different. The composition and structure of the exchanges will look a lot different. I think the idea of state-based marketplaces doesn't go away, but the way that they regulate those and the way they subsidize people to go into those markets will change quite significantly. So, this is much more in play than I think people currently appreciate right now. And if it wasn't for the fact that we, have so much more going on right now, I think that this would be a far more prominent issue in the election, but people just haven't really focused on it yet because the idea of a Supreme Court decision is sort of esoteric probably to most individuals, and they'll wait for the ruling. But, the courts with the current composition of the court, or the composition such as it's going to be after the current justice gets seated, presumably by the end of the month, doesn't seem favorably inclined to rule in favor of the Affordable Care Act here. So
yeah. However, even in the scenario with a President Trump winning the election in a Republican Senate and a reconstituted Supreme Court or a new justice on the Supreme Court, the idea of north of 10 million people losing their coverage.
I think that's right. I think something comes in, right? There's going to be a state-based exchange. There's going to be a marketplace. There's going to be coverage. There's going to be some subsidy provided for that coverage. I mean, the basic structure of the Affordable Care Act, I don't think goes away. It just ends up, the marketplace ends up looking different in terms of what gets offered in those exchanges. I think that's where, and the way people get subsidized.
Okay. Geraldine or Ted, anything you want to add to that?
No, I don't think so.
I'm going to shift gears just a touch and move on to the next topic, which is payment reform, because there's really a lot of things going on with regards to payment reform right now. And probably the first one that's at the top of the list for radiology right now is the change to the Medicare conversion factor. As we all know, there was a reevaluation of E&M codes in particular, which has led to a change to the Medicare conversion factor. The factor, as currently planned, will get cut by more than 10%, which will have a dramatic impact for radiologists and a number of other specialties. And it's important to note that not only has the conversion factor not kept pace with inflation, but the proposed 21 factor is actually lower than the conversion factor from 1994. In 1994, the conversion factor was 32.90, and the proposed rate for 2021 is actually lower than that. So, and that's not even considering inflation. If you take the inflation and adjust that 1994 rate, it would be about $58 inflation adjusted. So, Geraldine, what do you think the chances are that this is going to get addressed before the beginning of the year? And if it doesn't happen this year, how's that going to impact radiology? And is there any chance for a solution to happen after 21?
So I will say a couple of things. We have the best government relations team in organized medicine, and they have certainly done an absolutely amazing job in thinking this through, and particularly important, I think, working across societies. I mean, this is not just an issue for us in radiology. There are many, many other physician groups and other provider groups that are impacted. So this is where this long-term relationship building is so important. We've all alluded to the fact that it's a very challenging time to get Congress's attention for anything. But you know, I'm very confident that we're doing absolutely everything we can. You know, we certainly may have some opportunities in a lame duck session. But to your question, or to your question about how it's going to impact radiology practices, I mean, this is going to be a real challenge. I mean, you know, we have seen, especially our small practices and practices in rural areas, who are an absolutely critical part of the community, not just as healthcare providers, but as small business owners. We've seen them really struggling. And you know, a big part of the work that we've done at the college over these past few months is trying to make sure that they are supported through the various relief packages as much as we could. But to add this cut onto the fact that they have had several months of, you know, markedly decreased volume, as I know you've all experienced, it is going to be challenging. And we worry about what the impact is going to be for our graduating residents and fellows who are coming out into the job market. But most of all, we worry about the impact on our patients. I mean, you know, I speak to you from a city where we've seen the inequities in our healthcare system starkly exposed. And the idea that we're going to reduce access in areas where, you know, there aren't many choices for patients, it's very worrying. So, you know, as I say, we have the best team in the world. But this is, I would say to all of the radiologists dialed in tonight, there has never been a more important time for us to speak with one voice about an issue than this one.
Yes, absolutely. So,
hey, Anthony, can I hop in here?
Of course.
Okay. So there's a bunch of things going on, obviously, from the political / legislative side. Congressman Mike Burgess, who's a retired physician, he's the top Republican on the Health Subcommittee for Energy and Commerce. He just introduced a bill with Bobby Rush, and that would be a one-year waiver of budget neutrality, and they would be using the provider relief funds to help pay for that one-year relief, if you will. There's a lot of folks who are concerned within our coalition that we have about 50 plus organizations, some provider groups, some non-MD providers, that then it becomes almost SGR 2.0, where it's like, okay, now we're fighting this fight every single year. Ideally, we would like something more long-term than 1 year relief from the EM cuts, but obviously if we're in the 11th hour and we have to start our negotiation process, that's something kind of in the back pocket. We are under the impression that Congressman Ami Bera, a physician Democrat from California, and Larry Bouchon, a Republican on the Energy and Commerce Committee, he's also a physician, Larry Bouchon. They are going to introduce a bill, we believe, within the next week or so. We're negotiating with them on kind of some of the devils in the details. We think there are some opportunities in their preferred language that they would like to introduce. So there's no shortage of potential options for a fix. Senator Collins just wrote a letter to Leader McConnell asking for budget neutrality to be waived. We have a lot of members of Congress who are very interested in this issue. Congressman Bera and Bouchon, they also just sent a letter to House leadership that has 153 of their House colleagues, 76 Democrats, 77 Republicans. In this environment, when you have that many members of Congress and it is that completely balanced between the two parties, that's very eye-opening. As you can imagine, it's very rare. So it goes to show the visibility that our coalition has been able to get on this issue. But going back to something that Dr. Farrar and I used to always talk about during his race in 2018, it's one thing to get a lot of people interested, but how do you get those interested people committed, right? And so we have a lot of folks interested on the Hill, but we really need 1, 2, 3, or 4, or 5 really important members of Congress to step up and become committed to this as something that they'll die on the sword. So I think there's a really good chance, but nothing will happen between now and the election. It obviously would be in the lame duck, and the date to look for is December 11th. That's when the continuing resolution that we're currently under expires. There's a lot of healthcare extenders around that time period that are also going to be looked at. So if something's going to be done, it'll probably be then. Now, also keep in mind, if the election flips things completely, and then even if this E&M cut goes into effect, you may not have SEMA doing what she's doing, and you may have a completely different HHS and a different CMS, and so that completely is a game changer too. That doesn't mean that they will be more favorable. They may be less favorable. We don't know, but that's another dynamic. Obviously, we don't want to get to that. We want to get it before the end of the year so it doesn't go into effect. But there's a lot of moving parts here, but there's a lot of interest, which is somewhat encouraging. We are cautiously optimistic.
Yeah, that's really good to hear. Now, I know you mentioned the SGR, and one thing that might be a little bit different about this particular issue compared to that, there's certainly specialties in this issue that fared better than others.
Right.
And so what has that done, have you seen, and this is to all of you, from a political perspective about the House of Medicine uniting in order to work on this issue? Has it created any friction between specialties? Have you observed that? Or has it brought specialties together to fight?
If I can jump in, I would say overall it's brought everyone together. I think so long as we're all on the same page, and I think we are genuinely, that we're fine with everyone who's getting the bump. We just don't want it to be at someone else's expense. If we are on that same page, the family docs are fine with us trying to pursue what we're pursuing, as are some of the other who are on the plus side of this. When there becomes suspicion that we're going to make some trades, that's when things get a little sideways. But I will tell you, with our coalition, AMA is on every call. They are very engaged with this. We are constantly talking with all these folks who could very easily kind of go out the back door on us and really try to mess this whole process up. So I feel like for the most part, we're on the same page. I think surprise medical billing has actually helped, because we've been so united on that issue that has created these relationships that Dr. McGinty referenced earlier. That's really been helpful across the board. And when you can go to Congress as a unified group of physicians, that's super powerful. It's when we're all divided where they say, you guys can't figure it out yourselves. Why are we going to get in the middle of a spitting match?
Mm-hmm. Absolutely. Thanks. Ted, if there's one thing, I know we have a lot of radiologists on the call today, if there's one thing you could ask them all to do to help support some of the legislation that you were talking about, what would you ask them to do?
Well, I have to say give the Rat Pack, of course, but I think honestly, I think radiologists have to realize right now that there are no longer geographical boundaries in what we do and what they do. It used to be you had to be a lobbyist in Washington, D.C. to really have impact with your member of Congress, unless you came, you came for your fly-in every year, you do it, for one day or whatever it is. But for the most part, folks couldn't have that interaction. But now you can. And what we're doing, we're getting radiologists to sit in on fundraising calls that are Zoom calls that they otherwise would never be able to do. And no matter how good of a job I tried to do lobbying, it's not the same as a constituent radiologist from the district who can, go into all kinds of anecdotal information about what's happening in the local community with the patients and the impact and volumes. That is extremely powerful. And making those connections with our local radiologists now, this is kind of one of the blessings in disguise with this environment that we're in. Otherwise, they wouldn't be able to do it, right? They'd have to fly into DC to go to a fundraiser. They're not going to do that. But now you don't have to fly into DC. You can just dial on to a Zoom call and you can participate. So I think the willingness to get involved is huge.
Great. So moving on to another payment issue that's really important to all of us. In prior years, I think all I heard about payment reform was QPP, value-based care, all sorts of changes happening to reimbursement. That's not like front page anymore. Is that because it's not as important? Has it been drowned out? What do you think is going to happen to value-based care programs and the QPP under a Trump administration or under a Biden administration? And I'll let whoever wants to jump in on that go ahead. If not,
Scott, you want to go first?
Look, I think these elements of payment reform are broadly bipartisan, and this is a more secular trend. So I don't see the Trump administration sort of affirmed a lot of these payment reforms, and they were really originated in the Medicare Modernization Act, and then obviously the Affordable Care Act adopted the sort of contours of this. But I think the basic philosophy is broadly bipartisan and largely secular. So I don't see the outcome of the election or what happens to the Affordable Care Act really affecting it. Obviously, the specific programs would change if the Affordable Care Act ultimately had to be recodified, but I think they would come back to a lot of the same things and maybe try to just, modernize the statute to take a combination of kind of what's worked and what hasn't worked so well.
I think we'd still like to see more opportunities that specifically recognize the value of what radiologists do. We haven't necessarily seen that happen through these programs. So I'd say I would hope to see that.
Yeah, we certainly hope so too. So let's see what happens. Another area that's starting to change a little bit is payment for a variety of technology-based services, particularly the area of artificial intelligence. We're starting to see artificial intelligence algorithms that can actually make diagnoses. And we've recently seen approval of a CPT code for an AI-based tool imaging. What do you see as happening there? We're going to see more of that? Are we going to see reimbursement coming for AI in radiology? Is the current environment, is the government able to keep up? Are they moving fast enough, or is the technology outpacing the reimbursement system? What do you think might happen in that area in both a Republican or a Democrat environment?
I'll jump in on that. I'm not sure I would see a huge difference, but I may be missing something. I think the ACR has been very clear that we stand on behalf of our patients and for the use of these algorithms in a safe and effective way. And we have obviously a great relationship with the FDA and have worked very collaboratively with them, most recently a comment letter on their exploration around autonomous AI. And I kind of wanted to stop you when you said make diagnoses, because we continue to believe that there's a great potential for these algorithms to augment what we do. but we certainly do not see them replacing radiologists. The question of where payment is applied is one that obviously we saw the Viz.ai algorithm being reimbursed through the inpatient rule. So, the foot is under the door. But I think, our role as a professional society and a professional community is to make sure that they're adding value and that they are protecting our patients and improving care.
Scott, I'd love to get your perspective on the ability of both the reimbursement system as well as the regulators to keep pace with the innovation that's happening with regards to artificial intelligence as it pertains to imaging in particular.
Yeah, look, you've seen the agency clear and approve through PMA a number of platforms now for AI, particularly in radiology. I think that there's a sort of modern framework for how the FDA is going to look to grapple with these, where it's sort of black boxy and you can't decouple the algorithm that's generating the answer. And what they've sort of broadly outlined is that developers can get approval or clearance for these devices by demonstrating their clinical utility against a reference data set. So if you can demonstrate their reliability against a sort of standardized data set, that's going to be sufficient, and the agency doesn't have to sort of rip apart the algorithm to understand how it works in order to give it clearance. And you've seen them now apply that principle, not just in the setting of AI, but also in the setting of next generation sequencing, where they've recognized the data sets maintained by the NIH for purposes of clearing NGS platforms, where you can sort of screen against a representative data set, demonstrate the reliability of the NGS platform, and get regulatory clearance for it. So I don't think that there is a real regulatory impediment. I think that there's a pretty clear path for how these things could get cleared through FDA. And as far as the reimbursement is concerned, I think they'll be treated like other medical devices, which is a pretty uncertain path in CMS. But CMS recently said that at least for devices that get breakthrough designation, there's going to be a much more certain path for getting reimbursement. And a lot of these do have breakthrough status when they come through FDA, these AI algorithms.
Okay.
Hey, Anthony, one thing I want to jump in on it, and this is not AI specific, but it's technology-ish, I guess, is telehealth. I mean, I think there is a lot of surprise by members of Congress about how well telehealth worked during the first month or two or three of the pandemic. And there's a lot of really positive feedback. There's a lot of bipartisan talk and support now of telehealth, and how do we reimburse it, and what is the impact? And I'm just throwing that out there as something that is really being discussed a lot on the Hill now, and I'm curious to see how that impacts as we move forward. Does that become part of a new norm, or is that just something to get us by during the pandemic? Because I can talk to the most conservative member of Congress or the most progressive, and they're pretty much on the same page when it comes to, I mean, for the most part, on telehealth. And it was really something that they all were talking about. And I think it's something that we need to be aware of.
That's a very good point. And obviously, in radiology, we've been doing telemedicine for quite some time and do quite a bit of it every day. So we're kind of at the forefront there, kind of leading the way. One more payment issue, and I'm sorry there's so many, but it's only because there's so many. And that's around the appropriate use criteria. So that was supposed to come into play for radiology this year. Referring physicians were supposed to consult a certified system to see if their test was appropriate, and it got, once again, punted. This is becoming a little bit like the boy who cried wolf. Each year it's coming, and each year we're all nervous and people are thinking about getting ready, and then it gets called off. Are we going to see appropriate use criteria happen, or is that going to disappear? How should we think about appropriate use criteria?
So maybe I'll jump in first, Anthony. And let's just say that the fundamental value proposition of the use of evidence-based appropriate use criteria in medical imaging remains the same. We know that there are choices that people make that aren't necessarily the best choices. The imaging armamentarium or lexicon is incredibly complicated, and especially as we see perhaps more advanced practice providers who we know tend to order more studies, there's a real need for us to make sure that, I'm quoting my mentor, Bill Allen, we do all of the imaging that's necessary and appropriate and none that is not. So, obviously, we thought it was very important to make sure that the benefit of that value add and that quality was available to our seniors. And it's disappointing that we're not doing it this year. Clearly, we had this little pandemic, so that's put us back. But we've also worked very closely with CMS over the years, and it's been difficult, I think, for them to think about the best way to implement it. So we'll continue to work collaboratively with the agency. We continue to believe that there is real value to supporting our referring physician and provider colleagues in driving appropriate imaging. The why is still there, so we've got to keep pushing.
Anything else that people would like to add on that? So, well, maybe in 2022, we will see it. Certainly we're getting ready, that's for sure.
Well, Anthony, I will say that a lot of people are using it already. I mean, we certainly, people aren't waiting for this. And I think there are many, many organizations and institutions that are using it and seeing a real benefit in terms of that value add for the quality of care that their patients are getting.
Yes, absolutely. And there's certainly a significant benefit for patients, absolutely. So hopefully we can actually get enough energy behind it to make it actually happen. Shifting gears off of the payment reform thing to our next major topic, I want to move on to COVID, probably the healthcare issue that's dominated the minds of most Americans more than anything else. And so I want to throw up a slide here for people to see. Give me just a second to get that back up. And what the slide here shows really is that surveys here show that when ranking how different countries have performed based on in terms of their response to the pandemic, it doesn't show necessarily that there's a clear winner, but that the U.S. does not fare well in terms of how they did with regards to response to the pandemic. Scott, I'll throw this one to you. Do you think this is accurate? Do you think this is justified?
Well, I don't think the U.S. responded well. I think that, but we've seen challenges with many Western democracies, quite frankly. I mean, I think the U.S. in certain respects probably performed worse than some other, some European counterparts, but there's been a big disparity in terms of how the Pacific Rim has grappled with this pandemic and how the United States has, and I think it sort of demonstrates that this is a respiratory pathogens, pandemic respiratory pathogen may represent an asymmetric threat to the United States. If you look at the Western Pacific Rim and you look at the collective experience of China, Japan, South Korea, Taiwan, Singapore, Hong Kong, Vietnam, Thailand, Malaysia, New Zealand, and Australia, and you collectively add up all the cases that they had on a daily basis last week, it's less than the number of cases that Houston had. So clearly there's a gap in the way Asian countries were able to deal with this pandemic, or countries in the Pacific Rim. You have Australia and New Zealand in there as well, and how we were able to grapple with it. They did much more aggressive testing and tracing. They had much better adherence to things like universal masking. China announced that they had 12 cases in one of their cities, and they are going to test all 9 million residents within a 5-day period of time. Now, we could never do that here. We don't even have the capacity to do that, even if we could get the social acceptance of it. But, there's a big gulf between what we were able to do and what we were willing to do and what other countries did to try to control this epidemic. So a raging epidemic wasn't an inevitability. It was just an inevitability here. I think that the original major shortcoming in our response to this was a lack of diagnostic tests. And most people sort of ascribe that to the CDC and the botched rollout of the CDC test. But even if CDC had rolled out their test perfectly on time and scaled it, we still wouldn't have had nearly enough diagnostic capacity. We always needed to get the commercial labs in the testing game. And so a phone call needed to go out sometime in January, certainly by February, between the FDA commissioner and those labs, LabCorp and Quest and BioReference Labs, asking them to scale up laboratory developed tests because there was a recognition we were going to need significant testing capacity in case this thing became pandemic. And that never happened. And so, FDA didn't finally reach out to those labs till the end of February and authorize them to enter the market with LDTs. It took them weeks to do that. We didn't have any measurable testing capacity till the end of March. By that point, the country was heavily seeded. And we can no longer use testing as a way to contain spread we didn't even have enough testing in place to know where the virus was spreading. So when we finally had to implement mitigation steps in mid-March, we shut down the whole country. We didn't need to shut down the whole country. We had to shut down cities like New York where there was a raging epidemic, but we didn't know where the spread was and wasn't because we couldn't actually test people for it. So we shut down Bozeman, Montana and Dallas, Texas, when in fact the virus hadn't reached those parts of the country yet. And we could have used containment to isolate the spread. We didn't need to implement stay-at-home orders. And so I think, people recognized that the stay-at-home orders were too broad, and it led to a backlash against the mitigation when in fact the problem wasn't the mitigation. The problem was with the way the mitigation was applied, but it touched off a political debate over the mitigation that we've never really gotten out from. And so it's colored our ability to do anything to try to control the spread. But the original, when history looks back at this, I think the original major shortcoming and mistake that we made was not getting in place diagnostic screening and the over-reliance on CDC and the CDC test and the CDC process, when in fact, even if that had rolled out perfectly and CDC had done its job, we still wouldn't have had anywhere near the testing capacity. Someone needed to call LabCorp and Quest and get them into the market. And I'm quite certain those companies would have spun up tests. I mean, there were times when I was at FDA when I would call major manufacturers and ask them to get in certain markets because we were worried about drug shortages or other public health challenges. And I don't remember a single time when a CEO said no. The big companies recognize that they have a public health obligation, and they will allocate money, go to their boards and allocate money to address challenges that public officials perceive. And so this was certainly a challenge, and I think that they could have been convinced of the need to get tests cooking earlier. The bottom line is, when you talk to the labs, they tried. At some point in February, they were trying to get tests into the market. The federal government made it hard on them because they needed access, for example, to the strains of the virus to use as reference standards to validate their tests, and CDC and NIH wouldn't supply it to them. One big manufacturer, one big test company had to go to their subsidiary in South Korea to get access to a reference strain in order to validate their test. Finally, it was supplied to them, but pretty late in the game.
Okay. If you had to make a few recommendations to the next administration, whether it's Trump or Biden, what would be the things that you would tell them, hey, here's the 2 or 3 things you've got to do differently in order to improve the scores that we've got, the public's perception of how we're doing?
Well, I'm not sure that I'd focus on trying to improve the public's perception of how we're doing. I'd focus on trying to improve the reality of how we're doing. There's things long-term we need to do differently with pandemic planning. We need to think about how to build capacities and resiliency in the system that we just don't have today, and we didn't have in the setting of this crisis. I think in the near term, what you can do is have a more coordinated response among states so that you don't have these state-based efforts that create regional effects. You have a more uniform approach across the country, because the reality is we have these regional epidemics, then we end up just constantly going through cycles of reinfection across the country. We never kind of get out from it. And so you need a more coordinated response in terms of how you implement mitigation across the country. And it's not shutting down businesses. We're not going to do that again. There's no appetite for that. I don't think we necessarily need to. I think we're going to endure a lot of death and disease to avoid broad stay-at-home orders. I just think it's not going to happen. So whatever the casualties are going to be, unfortunately, they're going to be, because we're not going to reach back to the kind of mitigation we did in April. But you could get more uniform adherence to limitations on public gatherings, wearing of masks, things that are, they're going to be unpopular to a degree, and they're going to limit, the full scope of what people can do. But if they can control the epidemic and allow kids to go to school and allow businesses to stay open, the economic cost of them are going to be less than what the implications would be if we just have continued out of control spread, because there's a significant economic cost from that. Even if we don't tell people they have to stay at home, they stay home anyway, and businesses aren't rebounding. Movie theaters are going out of business, restaurants are closing. So, we need to kind of control the spread better if we're going to have economic activity rebound in any meaningful way. So I think that's what a new administration can do immediately. This administration is not going to do that. They see it as antithetical to to how they perceive their political base. And I work for the Trump administration. I'm not saying anything that's pejorative. They kind of proclaim this. They have a perception that these are political issues. I don't perceive it that way, but I don't think that they're going to change their posture with respect to things like masks or the role of the federal government relative to states in responding to the pandemic.
Okay. Just shifting gears just a bit, but still staying on COVID, there's a recent poll by Gerard, a public relations firm, that shows that only about half of the respondents in their poll were extremely or very likely to get a vaccine if one was available. And a different poll showed that more than half of those surveyed worried that political pressure from the Trump administration will lead to the FDA to rush to approve a vaccine without making sure it's safe and effective. And Scott, given your prior role, I think this is most appropriate for you. How do you see election politics impacting the vaccine debate, and what kind of impact do you think that might have on us being able to get sufficient immunity across the population to get back to some sort of normal?
Look, the reality is, I think once we get past the election, perceptions hopefully are going to change around a vaccine. I think a lot of this is being shaped by the fact that the outcomes from these trials, and I'm on a board of Pfizer, which has one of the vaccines in advanced development, the sort of potential readout from these trials is straddling the national election, and the White House has made hasn't been shy about, talking about their intent to try to tip the scales here, and they've said that. I'm not casting dispersions on them. They've actually said that they would seek to do that, although I don't think they're going to do it. But I think when people sort of step back and we get past the election, they look at these clinical trials. These are the biggest outcome studies ever undertaken for any medical product, probably in the history of the world. I mean, we've never done vaccine trials this large before, of this magnitude of a product class. And the largest vaccine trial that I remember was the rotavirus trial, which was 65,000 patients. We have Moderna doing a 30,000 patient trial, AstraZeneca 30,000 patient trial, Pfizer 44,000 patient trial, J&J 60,000 patient trial. The collective clinical trials here for a single product class are just enormous. And their outcomes trials, the reality is in 2009 with the H1N1 swine flu vaccine, we licensed that entirely on immunogenicity data. We didn't require outcomes trials, and there was reasons for that. We used a very tried and true approach to making that vaccine that's used to make the seasonal vaccine, and so we felt we could extrapolate. But there was no guarantee that a vaccine platform and a vaccine construct that was effective against a seasonal flu strain would have the same level of efficacy against a pandemic strain. But we made that leap of faith. If we would have required outcomes trials, we wouldn't have had a vaccine within 6 months. And so the data that we're going to have around these vaccines is going to be an enormous data set in which to make decisions about safety and efficacy. And if you go back 4 months ago, there was a lot of concern and angst that the FDA was going to allow vaccines for COVID to be licensed on the basis of immunogenicity data alone. The agency went in the exact opposite direction and required enormous outcome studies. I think that their vaccines are likely to be introduced to the market under an emergency use authorization, where it's going to be a very staged market entry. And the people who are going to be eligible for the vaccine are going to be people who, in a sort of incremental fashion, the perceived benefits or the potential benefits of the vaccine outweigh any theoretical risks associated with the fact that you're not going to have all the long-term follow-up data. So for an 80-year-old in a nursing home who's not only at high risk of contracting COVID, but high risk of dying from it if they do, if a vaccine is otherwise effective, that vaccine may make a lot of sense for that individual, even if you only have 2 or 3 months of follow-up data. So you don't know all the long-term safety questions, all the theoretical risks that might become manifest 6 months or 12 months out. For a 35-year-old, it wouldn't make sense because, the theoretical risks are concerning, the potential for long-term side effects, and the potential benefits for that individual are low. They're not likely to have a bad outcome from COVID. And so what the FDA is likely to do is initially authorize it for that cohort for whom the risk benefit makes sense. And then as you gather more safety data, kind of walk the approval down the risk benefit continuum and authorize it for successively broader groups of people based on their potential benefits relative to the perceived risks at that point in time. And so when you have 2 months of data, follow-up data, the risks are greater than when you have 4 months of follow-up data and you haven't unmasked any untoward side effects, and then you have 6 months of follow-up data and you kind of get a greater assurance of the safety of the vaccine. So it's likely to be walked down in that fashion. So it's not going to be broadly available in 2020. I don't think it would be broadly available for the general population until probably the end of the second quarter in 2021. So by then we'll have a lot of data associated with the vaccine. I think perceptions will change, and we'll have come through a pretty significant, probably epidemic this winter. So I think people are going to have a different view of getting vaccinated ahead of the fall and winter 2021 season. We'll see, but I think attitudes will change as more data is accrued, and as we, unfortunately, the potential for a pretty difficult experience with this virus heading into the fall and the winter of this year.
Okay. Just so if you kind of sum all that up, are looking at next summer, are we going to sporting events and concerts, or are we still staying in small groups and wearing masks?
Well, I think that will be, if we come off sort of a dense spread this fall and winter, and you kind of get to 15-20% of the population that's been exposed to this, maybe even more, you're getting to a point of exposure where the RT starts to decline. You're entering into the spring and summer when a respiratory pathogen like this shouldn't typically spread. So it's starting to come out of the pandemic phase and enter into a more seasonal pattern of spread. It's not going to be like a binary point in time when suddenly the pandemic's over and this coronavirus is a seasonal virus. It's going to be a gradual transition over the course of a couple of years. But I think that the spring and summer could be, relatively quiescent, relative certainly to what we're going through now. But I still think that there's going to be precautions taken. I don't even think next winter, even if we get a vaccine, we're doing all the same things the same way again. I don't think we're packing people into conference rooms the same way we did. I think we're going to look to de-densify things. You're going to see hand washing stations all over the place. I think masks are going to be more common. I think there's going to be limits on how many people could crowd into an elevator. I just think there's going to be certain things that are superimposed on society for a period of time that we're going to treat respiratory pathogens in the winter differently. As long as COVID is circulating, it's still going to make certain people sick, and you're going to want to control spread. We can't be as complacent about this as we are about the flu. Not least of all because we can't sustain the dual productivity impact of having a flu epidemic and a COVID epidemic every winter. I mean, I think that the cumulative impact on productivity and death and disease will be too much. So we're going to have to just be more vigilant about respiratory pathogens in the wintertime. And I think the idea of getting across the threshold of a public venue with a theater with a fever in the future is going to be not going to be so easy. And coming to work when you don't feel well is going to be objectified. It's not going to be seen as a sort of sign of someone toughing it out, but you're going to be told to go home. So things are going to be a little different for a period of time. I mean, I think slowly we'll get back to, the way we kind of lived before this, but maybe not totally. I mean, I think there's certain things that we probably will do different in perpetuity. And certainly we've popularized the use of technology to limit interactions and discovered that we can have pretty good interactions with technology, and it probably improves productivity if used correctly.
Yeah, thank you. I have one more, and then maybe we'll do a wrap-up question, maybe take a question from the audience. But this next question is moving into the next topic, which is trust. And a recent Kaiser Family Foundation poll found that nearly half of adults hold at least one misconception about coronavirus, including 1 in 5 saying masks are harmful, and 1 in 4 that say hydroxychloroquine is still an effective treatment. And with regards to the CDC, that same poll showed that trust in the CDC went from 83 to 67%. Amongst Republicans dropped from 90 to 60, and trust in Dr. Fauci went from 77 to 48 amongst Republicans. Recently, Fareed Zakaria published a book, 10 Lessons for a Post-Pandemic World, where he talks about trust in governments and institutions being one of the characteristics of countries that have fared well in handling the pandemic. So a lot, trust issues here, some notion that trust is actually a characteristic of countries that have done well. And then there's the role of what role do physicians have in creating that trust. And the thing I want to pull up is a slide here. Try to get for you guys with regards to the role of healthcare here. And the New England Journal, in an op-ed, just recently waded probably further into politics than I've ever seen them go since I've been a physician. And this is just a quote from the article. What do you make of this? What do you think the role is of medical journals and physicians in terms of driving, participating, helping to create trust in their institutions across the country, and the potential impact of things like this on the pandemic and how this has all gone?
Well, I mean, the New England Journal always waded into politics, and I think that's part of the problem. Is a journal that's supposed to be a neutral arbiter of scientific truth and scientific fact always had a political veneer and, frankly, a partisan veneer. So I think that's part of the problem, is that why institutions are questioned is because they're not seen as neutral arbiters, and the institutions that sort of should be objective don't behave that way. But this is part of a broader trend of growing distrust in institutions generally, growing distrust in scientific institutions and government agencies. It's been accelerated, I think, in recent years, but we've been on a downward trajectory when it comes to people's willingness to trust institutions and trust an expert class. And it's seen as in sort of a negative light by a good portion of the population, and that's really troubling. So I don't think that this is just something that's going to get reversed in a political cycle. I think this is far more cultural and secular, and it's not. In some respects, it's the demagoguery of elected officials, and you could point the finger at individuals and the political class, but in some respects, it's the institutions too. The institutions have behaved in a way that calls into question their objectivity, and I think the New England Journal's Exhibit A.
Any other comments from
Anthony? I might add that, and I know you know this, one of my passions is diversity in healthcare leadership and making sure that our patients' voices are heard. And let's be clear that our scientific organizations and our medical profession, our history isn't blameless when it comes to not necessarily really putting our patients first. So one of my vacation reads this summer was Medical Apartheid, which was a painful read. So I think if we're to learn anything about how to engender trust or gain our patients' trust, is that we have to bring their voice to the table. I'm so proud of what we've done at the ACR, bringing patients on our committees. We have on our journal patient editors, and making sure that our professional community reflects the patients we serve, so that they see us as knowing their lived experiences. So I'll just sort of, perhaps elegantly sidestep your question, but just say that I see this as just another imperative to make healthcare leadership more diverse and to really reflect the voice of our patients and their needs and values.
Yes, very well said. I have one from the audience. I've been trying to weave in questions from the audience into my questions to all of you, but one that's a little bit off that I want to make sure I get. It's for Scott. As a former leader as the former leader at the FDA and as a current partner in a financial company, you've been exposed to many innovative individuals, companies, and ideas. AI is a very hot topic right now. The ACR has promulgated guidelines on requirements for approval and acceptance of new applications. The FDA has indicated a more accelerated approach to approval of diagnostic and therapeutic products. How do you feel about that new approach, and what insights can you bring to the fore about the benefits and risks of that paradigm?
Well, I mean, I helped engineer the approach. I mean, one of the last things I did when I was at the agency was make sure that the white paper laying out that paradigm got out, because we spent a couple of years working on that. I think the idea that the agency doesn't have to sort of rip apart a piece of technology to understand how it works, but can approve it or clear it based on a demonstration of its validity is a modern sort of approach to regulation. I think the idea of pre-certification rather than requiring pre-market approval for low-risk technologies is a modern concept of regulation in the agency's pre-cert model. And it's a little bit afield from this, but the place where this was sort of demonstrated was in the approval of the Apple Watch, the ECG reader on the Apple Watch. I think people who watched this closely were stunned by that, decision by the agency because they expected FDA to rip apart the Apple Watch and they expected Apple to have to sort of show how the entire watch worked. And instead, the agency just required the validation of the software and the demonstration of its clinical validity without having to look at the Apple Watch and look at every aspect of functionality of that watch. And so that kind of shows that they're willing to decouple the output from the device, if you will. And I think that is going to facilitate the clearance of these AI platforms, that concept.
Thank you. I know we're about out of time, so I want to wrap up. If you guys could each leave our audience with one recommendation. If there's a lot of physicians on the phone right now, you're a radiologist, you're managing a practice, lots of issues that are really important in the election coming up. One piece of advice that you would give somebody running a practice today?
Well, I'll just start. I think we're going to have to be very proactive as physicians, trying to make up for all the missed medical care and the accrued morbidity, because on the back end of this, I mean, there's going to be huge clinical and social costs to what we've done this year. And I think a lot of it was unfortunately necessary. And a lot of it was born of the fact that, we didn't have a good coordinated approach to how we dealt with the pandemic. And so we ended up, I think, having an approach that in some respects was more costly than it needed to be if we were able to target our approach and our mitigation, our interventions better. But we are where we are right now. And I think that going into next year, doctors are going to have to be very proactive to try to get patients back into care and make up for a lot of the missed screening, the missed vaccinations, the missed routine healthcare, the accrued mental health, and the increased use of drugs and alcohol, and the weight gain, and all the other morbidity. I think that has been accrued over the course of a difficult year.
Geraldine, any advice?
I would say as I said earlier, there's never been a more important time for us to speak with one voice. We have so much to do to make sure our patients get the care they need, to Scott's point, but to make sure that our practice and our profession survives. If we have trainees who are listening in, it's still the best career in medicine. Sorry, Scott and Anthony. And we want to make sure, my goal as an ACR leader is to make sure that you get to have the practice that you deserve, and that you get to really enjoy practice the way that all of us in senior leadership have. So we do that as a unified professional community. So stay in touch with us.
Thank you. Well, I want to thank all of you very much. We're out of time. This has been a great panel. I really appreciate the time that all of you put into this, and hopefully I can see all of you soon, live and in person versus on Zoom. So thanks again, and we'll all watch this election closely.
Bye.
Thank you.
Thank you all.